Good evening, everyone. Here I am Andraos. Again, we are live. I am live from Dubai, and today we have a legendary Professor Youssef. He's from Lebanon and he's well-known bariatric surgeon. Today, our discussion is very interesting about gastric plication plus. So, gastric plication plus is a new idea that also Professor Youssef started, as you know, about more than 2 decades. So we can see so gastric plication, we lot of complication, weight regain, different discussion, but this plication plus, so definite it is a new topic in my opinion. And if you remember, in our previous discussion we have discussed about mgb2, and again today Professor Robert Rutledge, he will be also live with us, and also he is interested to comment on gastric plication. Professor, so much thanks for your time. I know you are so much busy, and in my opinion, this session will be one of the best session. Sir, please.
Thank you, Amran. I will start by saying a little overview about what we say about gastric plication, about what plus what. It's a plus a SADI, it's a plus a SASI, it's a primary, it's a secondary SADI, it's a primary SASI. We will try to put ideas on all those topics tonight, but let me start by my personal experience on gastric plication and the score I presented at the American College of Surgery on 2019 as a video session. Till now, over 15 years, we have performed 2,700 gastric plication. And when we say gastric plication, we say greater curvature laparoscopic plication, not anterior, not posterior. We are very specific on laparoscopic greater curvature plication. And I insist that all my topic will be on greater curvature plication, because this is the only procedure that have been studied and there is clinical trial and it is efficient. And the first publication was performed at Cleveland Clinic by Stacy Bithauer in 2010, and it is well mentioned that it is efficient and very efficient on comorbidities and weight loss. Well, I have developed this score concerning many points concerning the dissection, the calibration, and the way of suturing, and the final aspect. And for each point, I have scored it. And if you get a score of 20 over 20, you are good at making a standard laparoscopic greater curvature plication. Otherwise, you don't have the right to say I am doing gastric plication. I will show those steps quickly. We will start by acting the greater curvature by opening making an adductor, and when we get into the greater sac, we will go downward till 3 to 4 centimeters to the pylorus. Then we will move upward to make a complete liberation of the posterior fundus. And once we liberate the posterior fundus, it's a must to visit the hiatus to see if there is any hiatal hernia associated, and if encountered, hiatal hernia must be closed in our unit. In this case, 2 centimeters are needed of intra-abdominal esophagus to be present in the abdomen to be sure that we don't have any esophageal thoracic migration. Once we finish the dissection, we will continue by making our anterior and posterior marks. Those marks can be done by methylene blue or by any bipolar marks. And once we finish by marking the posterior gastric wall, we will start our suturing process, noting that short gastric vessels are not a good repair. We start our suturing at the level of the GE junction by folding it. We anchor the stitches, and then after we will go downward by folding the stomach and suturing it in multiple bites, accordion-like sutures to decrease the gastrogastric space and thus to decrease gastrogastric seroma and to decrease nausea and vomiting in post-operative phase. Once we finish joining the posterior and the anterior marks and collapsing the gastrogastric space, we will change our direction towards the antrum horizontally till reaching the 4 centimeter at the level of the pylorus. Then we will go backward for a second row of running suture, distant 5 millimeters from each other, to decrease the chances of gastrogastric herniation until we met the upper running suture row. Once they met, we will finish the gastric plication, and this is what we call a symmetrical, well-calibrated gastric plication. This is the final aspect. You can see. I hope you are seeing you are enjoying the final aspect with the symmetrical absence of the gastric plication and a complete restriction. And you can see a score of 20/20 if you make your gastric plication this way. You will reach a maximal restriction. And then to speak a little bit about what is gastric plication plus, in our experience, we have around 350 SADP as a primary procedure, and we have around 250 SACP, and we have around 100 primary SAGP, and as a secondary gastric plication plus, we have around 100 case of post-sleeve gastric plication plus, post-band, and post-gastric plication for weight regain. To start, we will start by the primary gastric plication plus. We choose our patients, those who has a high BMI greater than 50, diabetic patient with a BMI greater than 40, and the length of the ileal loop is tailored at 3.5 meters from the ileocecal junction. Once we finish the gastric plication, here is a short video on how we perform the primary gastric SADP. We will make first our dissection downward until reaching the gastroduodenal artery. And once we reach the gastroduodenal artery, we will make attention to the pancreaticoduodenal vessels, veins, and arteries. And we will join the anterior duodenal wall from the upper side by simply opening the peritoneum. You will see it from the anterior side. It is transparent, and once you get this area, your window is done, and you can continue upward towards the posterior fundus, and once you reach the hiatus, you will see there is any hernia to close. And if you don't have any hernia, you don't make anything, you keep the hiatus intact. But if you find the hiatus enlarged, you have to close it to avoid all kind of intrathoracic migration. Once you finish the dissection, you will put your anterior and posterior marks. Then after putting the anterior and posterior marks, you will fold the stomach as usual in a standard way in multiple bites by 2 rows of running suture, non-absorbable 2O. And this way you will make your gastric plication reproducible, and you can learn it to all your fellow and resident when you make those standard steps. You will get the maximum of restrictions a procedure can give. This is why, if you follow those steps, you will be among surgeons who make gastric plication. If you don't follow those steps, I have seen some videos who calibrate the stomach over a 60 French tube, and some surgeon who perform the gastric plication by separated stitches or a combination of separated and running suture. But instead of this, the most efficient in our hand way to perform a gastric plication free of complications is by making 2 running suture by 2O non-absorbable. Once we finish the gastric plication, we will go downward and transact the duodenum without any tension. You can choose any material you want to transact the duodenum, and you will measure upon your patient BMI and comorbidities 3 meters, 3.5, or 4 meters to make your duodenoileal anastomosis. It's a hand-sewn anastomosis, and we will start by the posterior layer, the first seroserosal layer. Then once we finish the seroserosal layer, we will go and open the gastric and the ileal lumen. We will enlarge it, and we will make the second posterior layer, seromucosal layer. Once we achieve this second posterior layer, we will attack the anterior layer by always an absorbable 3O suturing thread. Here we are starting to make the anterior full thickness duodenouileal layer, and we will continue until we join the first seroserosal and the first seromucosal layer. Then the thread is noted. We will reinforce it by a second layer of superficial seroserosal suturing. This is the second anterior row. And by the end of the surgery, we will make a patent and leak test using methyl blue or polyvidone betadine. This is what we call primary SADP. We choose it for the high BMI patient. We choose it for the high BMI with diabetes and for patient who has a lot of comorbidity and cannot tolerate complications of leak and other kind of complications. The second case I will present is also a gastric plication, a secondary gastric plication, post-sleeve gastrectomy for weight regain in BMI greater than 40, or in gastric plication, weight regain, or in uncontrollable diabetes post-sleeve and with BMI greater than 30. The sleeve is completely liberated in this session, and the most accurate technique to measure the capacity is by inserting an NG tube into the stomach, and the surgeon will block the pylorus by external compression, and the anesthesiologist fills the stomach with physiologic serum until the liquid comes out from the patient's mouth. If the gastric capacity is greater than 300, the sleeve is plicated over a 40 French tube for sure. This is a case of a weight regain after sleeve gastrectomy. We will start by making an extensive adductolysis. And once we finish by entering the greater sac, we will go downward until we reach the duodenum. And once we reach the duodenum, we will start to dissect the pancreaticoduodenal vessels. They are fragile. You have to choose a very thin instrument to dissect them and to take them one by one, posteriorly first, until you reach the gastroduodenal artery. And as you are seeing, they are here. Do not injure them. They will fill your field by blood, and the dissection will be very difficult after this to make. Once you finish the dissection downward, you will go upward to the hiatus to verify if there is any hiatal hernia. If there is no hiatal hernia, you will go and start your sleeve plication this way. In this case, you cannot calibrate because there is a lot of adhesions. There is a lot of problem to put marks. Sometimes I had put stitches to mark my plan, and sometimes I have put methylene blue, but in any way, it's very difficult to cut or to do other techniques. Seeing those fibrosis and those adhesions, I think the safest way to fold a sleeve is by doing a gastric plication. Otherwise, you have to choose another procedure like the SADI as without trimming the stomach, or a Roux-en-Y gastric bypass if it is associated with a GERD. In this case, I think the most accurate surgery will be a Roux-en-Y gastric bypass to well calibrate the gastric pouch. Once you finish holding the stomach, you will go and continue your second row, going from the pylorus till the GE junction. And when the two rows met, you will note them. And this way, you can have the exact calibration and restriction over a 40 French tube. Sometimes if we don't have a lot of adhesions and a lot of fat around, we can put a 36 French tube because there is not a lot of tissue to fold. Once we finish folding the sleeve, we will go and transact the duodenum without any tension, because I will mention later on why we don't have to apply any tension to the duodenum, because it is very important to keep the thickness of the duodenum in a neutral position if you want to avoid duodenal stump leak. Well, once we transact the duodenum, we will go to the ileocecal junction, and we will count according to the criteria of the patient, 3 to 4 meters. It is not standard in my practiced to make a 3 meters ileal loop, neither a 4 meter. It depends upon the patient status, diabetes, and BMI mainly. They will guide the length of my loop. Once this phase is achieved, we will go, and I think I have shown already the same anastomosis. Maybe we will move to another video, interesting. But let me show you the single anastomose duodeno-ileal with sleeve plication for weight regain after sleeve gastrectomy. This video will treat all the failed gastric sleeve if you don't choose to go and make a mini gastric bypass or a Roux-en-Y gastric bypass or a SADI-S. You can do this for less complications. Let's move to another video and we'll see if secondary gastric plication for failed gastric plications, those patients who have weight regain after gastric plication. You can see my gastric plication 7 years after, it's stable, there is no herniation, it is well calibrated, and you go, you do the same liberation, you will reach the gastroduodenal artery, you will see it, and you will open the anterior peritoneum. Once the anterior peritoneum is open, you will join the posterior layer. As you can see, here we are very careful to pass on the superior border of the duodenum, avoiding the choledoch, the common bile duct, and you are seeing this is a huge liver, but always we don't put any tension on our duodenum. Once we finish the duodenal transaction, we will continue and we will make the duodeno-ileal anastomosis, and in some cases, if the stomach or the gastric plication or the sleeve is not very dilated and the capacity is less than 300, we are not obliged to make any restriction or to refold any plication. You can keep it or you can fold it. You can jangle with the malabsorption and choose 3.5 meter or 3 meters in case of weight regain instead of long common channel loop. This is a case also of secondary SADP. We will move now to speak about Professor Robert Rudlish technique, our technique, which is the SASI, is a primary gastric plication plus. We have described the common loop is tailored in those cases at 4 meters from the ileocecal junctions. Greater curvature is plicated in the antrum at 6 meters from the pylorus by 2 rows of running sutures. This technique may compete with MGB2. Anterior gastric plication, gastric antrum plication, gastrojejunal anastomosis at 2 meters from trace. Our indication is for patient when we make this technique, when the patient's BMI are between 35 and 45, 45, and the patient conditions allow it. And if we encounter a difficult duodenal dissection or a lot of adhesions with the previous surgeries, we move to make a primary gastric plication plus, SASI plus. This is the same technique. You will make a gastric liberation until joining the hiatus. Once you reach the hiatus, you will dissect it. And if you have a huge hiatal hernia, like in this case, we will dissect it until we have 2 to 3 centimeters of abdominal esophagus free of tension in an intra-abdominal position. Then we will close the hiatus with 2X or 2 separated stitcher, figure of 8 or U-shape. Any procedure you can choose. We are used to make separated stitches free of tension to keep all our plication later on in an intra-abdominal position. Once we close the hiatus, we will go and we will make the anterior and posterior plication. And once we finish anterior plication, we will stop it in SASI at 6 centimeters from the pylorus. This will allow us to make an anteroileal anastomosis and not a duodenal anastomosis. And the landmark is the vertical part of the crow feet at the horizontal part, a vertical part. Once we finish the first row, we will draw back and initiate a second row from below the first one. And you will calibrate also the same manner the gastric plication. And once we finish this step, it takes around 20 to 30 minutes to finish it. We will attack and calculate the length that we choose for SASI is 4 meters, and we don't close the pylorus. We don't stitch the pylorus. We calculate 4 meters and we go until we reach the desired length of ileum. We will make our first row of seroserosal layer. Then we will open at the level of the antrum. We will find the mucosa. We will go and open the antrum anteriorly between the greater curvature and the anterior wall of the antrum, and then we will attack the ileum, and we will open a well-measured anastomosis of 3 centimeters that I will show later on how I make it at 3 centimeters by introducing an instrument to measure the exact length, and not more than 3 centimeters for any gastroileal anastomosis to avoid diarrhea and excess weight loss and malnutrition. Once I finish this procedure, I avoid to make it in diabetic, and I know a lot of surgeons are proclaiming it to treat diabetes, but once we don't close the pylorus, I think we cannot achieve a good control of diabetes. This is why primary gastric plication plus SASI-P or staples gastric plication plus staples gastric plication plus is an ideal procedure for all patients for any BMI by tailoring the common loop, the ileal channel, and we can go from 3 meters to 4.5 meters with a gastric plication well calibrated over a 40 French tube. Once we finish our surgery, we can attack the anterior layer by a seromucosal plan, and this way you will have a wide gastroileal lying horizontally on the abdominal fat without twisting and without any stenosis. And pay attention, the biliary limb direction parallel to the alimentary lip, parallel to the alimentary lip, the common channel. This is the second layer of seroserosal suturing, and I think we are straightforward. We are making a restriction within the limit of the restriction. We are making a malabsorption procedure. This procedure is completely reversible at any time, and it is physiologic. Once they create other medicine, you can propose to your patient to unfold it and take down the gastroileal anastomosis. This is the final aspect with the methylene blue and patent test. And here we will discuss also another case of secondary gastric plication plus SASI for post-sleeve. If the duodenal dissection is difficult, is the BMI is greater than 30, post-band, and when the patient has gastric band, I prefer to make a SASI instead of SADI because the visual capacity is big, and if you keep the pylorus in place, you will have a big stomach and a big esophagus, and the gastric and the visual capacity are very high, and you will lose on restriction. This is a case of a sleeve, a secondary gastric plication plus SASI post-sleeve gastrectomy for weight regain. Here we are a special liver retractor, and it will be developed in the coming months. You can ask for, and we will attack the sleeve by making an extended adductolysis, and we will once more visit the hiatus, and unfortunately every time we visit it, we encounter a big hiatal hernia, which is an origin of all the patient's symptoms and post-op vomiting, nausea, pain, chest pain, and excess weight loss. You have a lot of problem if you don't check your hiatus. Once you check your hiatus, you will go downward to liberate the antrum till the pre-pyloric vessel. I will show you the limit of the dissection downward, posteriorly and anteriorly. And here we can see the pre-pyloric vessels. And I think when you see those vessels, you have to stop. To avoid putting the esophagus aside, we retract it laterally, and we will close after dissecting 2 to 3 centimeters of abdominal esophagus. We will close the hiatus, and we will start by folding the sleeve gastrectomy to achieve a good restriction, knowing that our capacity test is performed perioperatively by asking the anesthesiologist to fill the gastrectomy by serum, physiologic serum. Once we close the hiatus, we will check our dog ear to see if there is any damage we have did, and we will start by folding the posterior wrap and the anterior gastric wall at the GE junction. As you may notice, you have a complete view on all the stomach, and you can know how much you are folding your stomach. And it is only attached on the short vessels, gastric vessels. Once you fold it, you will see by palpating the intragastric fossa tube that your restriction is enough, and you will continue it until you reach the antrum, that you will open and make your gastroileal anastomosis. For weight regain and in BMI greater than 40, the gastroileal anastomosis is performed at 3.5 meters from the ileocecal junction. This is the final aspect of the vertical gastric plication post-sleeve gastrectomy for weight regain. And once we finish this part, we will go downward to the ileocecal junction. We will measure the adequate length, and we will make a hand-sewn anastomosis. You can always make a mechanical anastomosis. We are used to make all our surgery by hand-sewn anastomosis. Here we will attack the posterior seroserosal layer. We start 2 centimeters from the pylorus, and we will achieve the first plan layer, and you will notice that by the end you will have a great plicated sleeve gastrectomy with a great single anastomose gastroileal bypass. I will move on because I have already shown a lot of anastomosis, but I will mention how I measure. I think it is in this video. We will open the mucosa. I think maybe in the last one. And this is a last video where we are making a SASI post weight regain on previous gastric plication. This video is so interesting. 8 years after gastric plication, you will see the stitches are stable. There is not a lot of adhesions. Few adhesions are here. We don't make any dissection furthermore. And all our patients, the majority of our patients, to not say all our patients, don't show a lot of adhesions because we don't have, after gastric plication, a huge or a big incidence of abdominal bleeding or gastric bleeding from the stapler line. I think over the 3,500 gastric plication we have performed between primary and the secondary, we didn't transfuse any of our patients, because when we make the gastric plication, we mention to our anesthetist to increase the blood pressure, and we wait and we remove the pneumoperitoneum. And when we open the gastric and the ileal lumen, we watch by increasing the blood pressure if there is any intraluminal bleeding. Once we finish downward the dissection of the antrum, we will go upward, and we will notice that there is no hiatal hernia. This is the first row, the first stitch of the first row, the old row, and we will start from the G junction to fold the stomach. And once we fold it over a 40 French tube, you will see it will be well calibrated. It's very difficult to cut into a sleeve plication. It's easy to unfold it, but it's very difficult to cut through the gastric plication, you can encounter a higher incidence of gastric leak, even if you are thinking that you are in a normal tissue near the lesser curvature. I advise to refold the gastric plication instead of cutting it, or to make a low pressure system like a mini gastric bypass or a SASI, resective mini gastric bypass, resective SASI, single anastomose, sleeve to ileum. Once you finish folding your plication, you will go and measure the, once you fold completely the previous plication that was dilated 8 years after, and the patient kept around 30 kg of his lost weight, but unfortunately he was starting from 140 and he was still at 110, and we have added the SASI in his case because he don't want to cut any part of his stomach or his duodenum. Then we will measure the ileum and make the same procedure on the posterior. This is how we measure. We take a 3 centimeter of thread and we mark it on the anterior wall by a cautery. We will see those are our 3 centimeter landmark. Then we remove our thread outside. We will open the mucosa by any instrument. You can do it by a monopolar or bipolar. We are used to use bipolar instrument. Then once you finish those those steps, you will check on the intraluminal aspect of your stomach to see if there is any bleeding. Then you will open the ileal part, and also you will check if there is any bleeding, and you will start to make your anastomosis and direct vision, and you will see if there is any bleeding. If you are noticing here you have a small bleeding, we will treat it by taking it into our suturing stitches. We will go and visit the gastric lumen and charge this bleeding and start the second posterior layer by apposition of the seromucosal posterior layers. Once we finish it, we will attack the anterior also seromucosal layer, and we will reinforce it by a superficial seroserosal layer, taking care to not take into your instrument stitches the posterior layer, which can make an obstruction of your anastomosis. Here is a final view of the secondary gastric plication, SASI, post-gastric plication for weight regain. And you have to notice that the anastomosis legs must be parallel if you want to make a good drainage for the bile and for the for the food to pass through the alimentary and common channel. This is the final aspect. And we have associated the gastric plication with sleeve alone without any bypass. We have plicated so many weight regain for post-band. We have plicated so many gastric pouch post-RO-NY and post-GBG. And we have encountered some complications patients, one case of peritonitis, without evidence of duodenal stump or gastroileal leak. We have encountered 2 cases of obliged to reverse to normal anatomy for severe and persistent hypoalbuminemia, and we have reverted them to normal anatomy because we have performed our transaction free of tension. We don't have any retraction of the duodenal stump. In conclusion, gastric plication plus is a plus for all pre-existing bariatric procedure. Is useful as a primary and revisional procedure. Gastric plication is safe, conservative, reversible. Gastric plication is needed as a bridge therapy in high morbid obese patient. There is a low rate of complication, mainly in redo surgeries. Managing the complications are so easy. You can unfold your plication and your problem is solved mainly. Gastric plication needs to be widespread among all bariatric surgeons. Training centers must be available worldwide. Governmental sponsorship is needed to help in treating obesity and its complication by promoting gastric plication and gastric plication plus. And thank you.
Sir, so much thanks, really. So you can click stop sharing.
Okay.
Yes, amazing, really amazing. And personally, I learned a lot. So, how you are doing? Because I am doing, as you know, gastric plication, how you are doing, and dissection. I have some question. So, first, my question: what is the relative contraindication of gastric plication? Have you any contraindication?
Gastric and contraindication for gastric plication.
Yes, the patient is suffering with GERD. So just like sleeve gastrectomy,
if we have a uncontrollable GERD, if we have an uncontrollable GERD, if we have any esophageal dysplasia grade 1 or 2, we make a gastroscopy to all our patients before performing a gastric plication. Any modification at the level of the cardia or at the lower esophagus, any metaplasia, any severe dysplasia, any predisposition to Barrett's esophagus is a contraindication to all kind of restrictions procedure, including gastric plication.
Sir, next, so when you dissect, a patient is suffering with hiatal hernia. If hiatal hernia is larger than 4 centimeter, so have you any experience to go for hiatoplasty and also gastric plication?
Yeah, we always reinforce our hiatal reparation, even by the round ligament or by an aponeurotic patch, by dissecting the posterior abdominal aponeurosis and patch it over the stitches on the left and right cross. We don't use anymore any prosthesis, non-biologic and non-synthetic. We use even the round ligament mainly if it is between 3 and 5 centimeter, and later we reinforce it by a posterior flap from the posterior rectus abdominis aponephrosis by rotating it and closing the hiatus and fixing it to the left and right cross. It's a flap of 7 to 10 centimeter of length and 7 to 10 centimeter of width, vascularized over the round ligament that you will rotate and touch your hiatal space. And it's a new technique that we are developing in collaboration with many other surgeons in US. I can communicate this short video, and I think you are knowledgeable enough to know that this is the future for the reparation of large hiatal hernia.
Sir, one thing that we are facing routinely after gastric sleeve gastrectomy is, so you know better than me, sleeve is Also, as we all know, reflexogenic. So this tag is now with the sleeve. And also there is chance of, personally I faced many patients, so sleeve migration to mediastinum. Have you faced, because now you have more than 1 decade experience of gastric plication. Have you faced such a situation like this plication or this plicated stomach migration to mediastinum? And also, what is the percentage of GERD after plication? Yes, you select the patient. If a patient is suffering with GERD, yes, you will not go for plication. So, but yes, you do this. But what is your percentage GERD after plication and migration after plication?
We are a little bit biased because we don't take patients without previous GERD exploration. The novel GERD is around 8%, 8 to 10%. We have, but it is easy to manage GERD after gastric plication. In worst case, you can unfold the upper part of the stomach and you can make a Nissen plication. And you can keep the lower part of the stomach. This is what we call, this is why gastric plication is completely reversible. By the end of the road, you can unfold it completely and you can treat your GERD by making only a Nissen plication or a Nissen Rossetti shortly. Otherwise, we have sometimes be obliged when we have a high BMI patient with GERD, de novo GERD, make a Roux-en-Y gastric bypass by unfolding the upper part of the stomach, making a gastric pouch, and making a Roux-en-Y gastric bypass for both GERD and IBMI patients.
I understand, but my question.
But managing GERD after gastric plication, it's easier. It's not easy, but it's easier. You will start by your medicine, and if you don't cure your patient by medicine, he will lose weight. Losing weight, it will help him. And if you fail to use all the methods, you can unfold your stomach, and you are not obliged, like in sleeve, to make the Roux-en-Y gastric bypass for GERD in low BMI patient.
Sorry, I understand, but my question regarding, have you faced such a situation and what is the percentage of GERD after plication? Have you any data?
Yeah, I mentioned 8 to 10% is our percentage of GERD de novo. We don't speak about GERD unless the patient's exploration was incomplete before the surgery. If the surgery we have performed didn't include a gastroscopy and a visual exploration, we didn't include it in our statistics. Maybe the numbers can be higher, but we include only patients with no GERD in preoperative phase. Confirmed.
Yeah. You also mentioned about so weight regain after Roux-en-Y gastric bypass and plication of dilated gastric pouch. In such a situation, we are also facing dilated roux limb, and some of surgeons they are doing a sleeve of roux limb as well as that pouch may be also in any presentation or you have witnessed about such a. Are you also plicate that dilated roux pouch or only that gastric pouch? You take my point?
What we have performed, we have plicated the gastric pouch many times, and we have very interesting video to show. We have plicated the anastomosis. We have reduced the calibration of the anastomosis over a 32 French tube, and we have put a minimizer over our plication. But we didn't plicate. We have resect a candy can. We have make a lot of surgery over the modification of the diameter of the gastrojejunal anastomosis, but we didn't perform plication on the alimentary or on the rulen.
Sir, excellent. Sir, as you are doing all of these surgeries with plication, I don't think industry like you.
Yes,
But
I think I'm not welcome by all those industry, and I think if you are interested or in sending surgeon governmental process or health ministry, and even in rich population and in poor population, because rich population are actually invaded by poor populations, and in both situations, safety and cost of obesity and bariatric surgery is a huge, not only the material, mainly the complications of those procedures on short and on mid and long term. I think all our residents or our intern or our fellowship, it's a must from the government and the Ministry of the Health to introduce a course, an official course on how to perform a bypass without stapling, how to suture without stapling, how to make sure that you are making a good surgery. And I have to tell you, all my surgeries from 25 years ago till now are fully recorded from A to Z. Even a small appendectomy till the huge revision, everything is recorded. And all the surgeries I have performed in bariatric surgeries are recorded. But it's a national plan. It's not a matter of industry. I'm sure that all the industries will not invite me to speak, as I will not sponsor me to go anywhere. It's not a problem. It works. Gastric plication, I want to give you a secret, was invented and tested, and it works. And when they conclude that it works, they have shifted the industries, shifted towards the endoplication from the mouth that they are calling endosleeve. It's a sleeve, but it's not a sleeve gastrectomy. The plication is a sleeve, but it is a sleeve plication. You got me my
yeah,
my point
of
of view?
course, sir. Yes, I know, and also in different platform, I was also witness how they are against plication, but they are support that endoscopic sleeve gastrectomy RESC. Okay, sir. Next, so I have little experience, not like you, because now I am also doing staple-less mini gastric bypass. What is step-less? Same like you, I am doing that plication. Then about 200 centimeter from DJ, it will be enterojejunostomy. Then I plicate pylorus completely. Now I have about 100 cases of this staple-less MGB that I named this. Now I started in 2016, and now during this period about 100, only 100 cases and excellent result. I remember after 5 years again I did a barium study, only that going like this loop, there is no like just MGB. Have you experienced to plicate pylorus only, no need to cut duodenum?
We don't placate pylorus because our selection for patients in high BMI and in diabetic, it's a must to cut the duodenum. It's a must. In low BMI, we think that keeping the pylorus permeable it's preventing the damping syndrome. There will be some part of the food that will pass through the normal channel, and we didn't encounter any damping syndrome if we don't fold the pylorus. You got the point?
Yeah, I
If
point.
you fold if you fold your pylorus, maybe you will get a one-way route for your surgery, but we prefer to keep two routes, mainly for the damping syndrome, and the results are the same. And at any time, you have a weight regain, you can go back and completely either cut the duodenum or fold your pylorus.
Sir, another thing that technically I was a witness during your demonstration. So first always you do plication, then you add your loop. But my experience is first always I add the loop, enterojejunostomy or enteroileostomy, then I plicate stomach. Yes, we did always gastrolysis. We prepare the stomach, but first we always go for enterojejunostomy or enteroileostomy. Then we plicate our stomach. Any
This
difference?
is a critical, yeah, there is a huge difference. This is a critical point because when you prepare your anastomosis and you did it first, okay, and you start to fold later on your stomach, the fold, if you approach a lot, your anastomosis will block either your pylorus and your anastomosis. This is why I fold my stomach and I open the and I will watch my intraluminal fold. If it is near the anastomosis, I will move it or I will remove some points. Otherwise, you will have a complete blockage because edema at day 1, day 2, day 3 will fill all the fold at the level of the antrum and it will block your anastomosis. And if you are saying that you are folding either the pylorus, you will have so much, not revisions, so much problem you have to wait and it will pass. But sometimes I remember 1 or 2 times early in my experience, I was obliged to go on the third day to unfold the lower part of the gastric plication because all the antrum was filled with gastric fold due to edema and to migration. We have had 2 cases, one case of pylorus migration of the fold and one case of fold migration into the esophagus early in our experience. This is why actually we are suturing in multiple bites our fold to make a fixed fold, not something that can move or migrate upward or downward or through an anastomosis. And another reason not close the pylorus, it's the post-operative course is fantastic because you are facing a low pressure system. You are facing a double lumen exit. You have an exit towards the pylorus, an exit towards the small bowel, and you will never have nausea and vomiting problem. All our applications that we don't associate with SASI, we keep them 24 hours under corticosteroid. But when we make a SASI, we can avoid anti-inflammatory and corticosteroid easily.
Sir, excellent, really excellent. And also, we have a lot of questions, definite, but due to shortage of time, sir, it was one of the best session because this, in my opinion, this is a hidden part of, unfortunately, our bariatric surgery, and we need to talk more and more about, especially for those countries, and also especially so in Pakistan now, Pakistan population. So we are a leading, unfortunately, in diabetic patients, a leading country So patients cannot pay the central obesity. So definite in such a countries when someone can do just with 2 or 3 prolin sutures and can provide such a services and low cost and effective, uh,
Yeah.
it will be really appreciable. And but need, as you earlier mentioned, to support industry, or especially organization must support us. If industry is not behind us, but like organization, a big organization like IFSO, they must promote such a cost-effective surgeries that will be more beneficial. Sir, just last question. I have not just have you any limitation of BMI, upper BMI? So how you can do?
You can use it as a first step procedure. Do a quick gastric plication, come back after 1 or 6 months after the surgery, and complete by a SASI or a SADI in a highly morbid obese. If you have a cirrhosis, even you can go and make child's A or B. You can go and make your gastric plication. Gastric plication, I think, but unfortunately, we don't have any governmental study who is ready to sponsor this kind of efficient and to promote this kind. Those kind of type of surgery must be a governmental project. If in Pakistan you have the way to reach the ministry or the government to introduce a clinical trial or a randomized clinical study over and a comparative study, I can bet with gastric plication only we can be better than gastric plication, and with SASI we can be similar or better than mini gastric bypass. But I don't agree with Robert Rutledge that anterior gastric plication is a restrictive part of the mini gastric bypass, and he has to think about associating the greater curvature gastric plication with single anastomose gastroileal at 2 meters from the GE junction, from the trace angle, or at 4 meters from the ileocecal junction.
Sir, so much thanks, and it was one of the best session. And this interview, so that as you remember, we have started about 3 years ago, and now this is our sixth session of interview. And every Tuesday evening, 10 p.m. Dubai time, and next week also we will be with another legendary bariatric surgeon, and we will talk another topic. And nowadays, because we are our main is deferred live and in different surgeries. Sir, again, so much thanks. In future also, we need your support, and maybe in future we will have another session with Robert Rutledge as well. So to discuss about MGB2 and as well as plication plus definite, that will be a fruitful discussion. How can we promote such a cost effective bariatric surgery, and maybe we will make any organization or any, I have no idea so how many people are doing nowadays gastric plication. We can talk about at least a WhatsApp group. We must be in touch with each other, and in my opinion we can start from now. We can add Talebpur, we can add so Ramos as well. He's also sometime doing, because I have discussed with him in he's also sometime doing in Brazil. So, but many of them. So in Mexico, I know some persons they are doing plication. We can talk with each other. We can promote this surgery. We can also take youngsters for training, because this is little tricky surgery and need more, especially learning curve. It is not just a stapling, handling the tissue, dissection, and how especially first stitch is very tricky, because you have fundus, how you plicate that area. If necessary, we can do a door plication at that area. So these are the tricky points. And so if with your permission, I will make such a WhatsApp group, and I will add some of them, and then maybe in future. So especially in those countries that need such a cost-effective surgery, so maybe we will be more effective. Sir, again, so much thanks. Really appreciable, and in future also we need your support.
Thank you.
So much.
Have a good night.
Thank you, sir. Have a nice time. Thank you, sir. Thanks, sir.